Thank you very much indeed for the very kind introduction, and for the organisers for inviting me back to this wonderful conference. Lovely to be in such an amazing room, and hopefully, since we're near the Houses of Parliament, we'll do some good debate afterwards as well. So I'm going to be talking about one of the other risk factors, having had the scene set really over the course of this morning with some very interesting discussions that we've had. So the first question is what is blood pressure when it's high? What does it mean? Why does it happen? Does it matter? Because obviously if we want to diagnose and treat, it's something to really reflect upon. Interestingly, as you mentioned, I lead the kidney transplant program here in the United Kingdom for children, and looking at our national and international data, I can even see that even when you have paediatric nephrologists like Stephen and myself looking after patients, and even when we believe that normalizing blood pressure is the best thing to do, when you actually look at the data of how many people do not aim for normal blood pressures, it is astonishing that it still happens, and it happens in my unit as it happens around the world as well. So I thought I'd set the scene because we've had discussions of various aspects which are important to patient management. So a 14-year-old boy who's on the 98th centile for weight, he's referred for hypertension because he has an elevated blood pressure on screening. He's a completely normal examination. His blood pressure in clinic is 2 millimeters of mercury above the 95th centile. So the first thing that I would do, obviously, is to say, does he have hypertension? And for me, the gold standard would be to do a 24-hour ambulatory blood pressure monitoring, which I'll talk a little bit about later, but this gives us a lot of data over a 24-hour period. So if it's normal, do you say this is a normal child, there's nothing to worry about? Would we give some health style advice? Well, I think we probably would from what we've discussed this morning. But obviously, with a more elevated blood pressure in clinic, it is possibly a white coat hypertension, and is this physiological or pathological? And I think the data would say at the moment that we still believe it's a physiological parameter, but there's some emerging data that those who have white coat hypertension are more likely to actually develop higher blood pressure as an adult. And then, of course, pre-hypertension and hypertension states requiring treatment. Obviously, there's not enough time to go through all of the data, but if you look at the literature over the last 2 years, especially in the British Medical Journal and Lancet, you will have seen the discussions which we really touched upon a little bit just now with hyperlipidemia as well, is that if you do not have multiple risk factors, are you going to do more harm by changing one particular factor, by having somebody who's on a medication for 10, 20, 30, and to be honest, with antihypertensive agents, it's mostly for the rest of your life. So I wanted to put this slide up because it touched upon what Professor Stevenson mentioned today, but one of the things which really interested me was that it's not just the obesity epidemic. And although he did also touch upon the iPad use and social media, but there is now increasing evidence that actually this sedentary behavior itself is an independent risk, irrespective of what your body mass index is as well. And in fact, one of the most interesting studies that I saw when looking at what is the effect of high body mass index in children after kidney transplantation is the one factor that was more statistically related, in fact, was the maternal body mass index. And I won't mention anything about who does the cooking in your house, because of course we're equal sexes nowadays as well. So the thing about high blood pressure in our normal pediatric population is that very often we're thinking about secondary causes. Could this be as a result of something else? And what we're seeing is that there is an increasing prevalence both in obese and non-obese children in developed countries, partly maybe related to, as we heard earlier, our salt intake as well. But I thought that I'd want to make my discussions and talk this morning up to date. So this is actually in this month's Archives of Disease in Childhood. It is actually a Dutch study where the central health authorities put out a request for 4 centres that do screening blood pressures to actually look at their data in more detail and to recall these children. So they ended up having 55% children who were overweight, so nearly 1,000 kids, 438 that were overweight children between 4 and 17 years of age. And what they did is they looked at their blood pressures and they brought them back and they recalled them, and they basically said, what is a normal blood pressure? Now, we'll talk a little bit about how to measure blood pressure, which for me is doing it manually and doing it with the Doppler, and not doing it on a non-validated automated machine. But when you go back to your general pediatric units and your pediatric specialist units, how many of you have got a non-validated Dynamat machine where you press the button and you get a number, and you don't like that number? So you press the button again, and you don't like that number either, and you press it again. And eventually the nurse doesn't write any of these numbers down because they go away and they come back, and eventually they get a number that's right because it's normal. Is that scientific? I think not. But anyway, what this showed is that if you look at children's blood pressure, so this was overweight children with a high blood pressure, so 3 measurements which were above the 95th centile, and you brought them back and you did a second visit, and you rechecked the blood pressures, and of course there were patients that didn't show and didn't follow up. But basically, there is a reduction in the number of children who probably are hypertensive. And of course, this would go against my belief, because in fact, what they didn't do was the gold standard was a 24-hour ambulatory blood pressure measurement to show that it's true. But what it does show is that maybe the prevalence of hypertension is dependent on a variety of factors, and maybe actually when you can reduce the blood pressure by doing repeated measurements, maybe we need to think about the basics first of all. But obviously it's very different considering a 12-week-old baby who was very sick, that was meconium aspiration syndrome, had acute kidney injury, and basically ended up being noted to be hypertensive. And you need to think about, what are you going to do? Well, for those kids who are at the other end of the spectrum that are younger with higher blood pressures, it's easier. You're going to do investigations to work out whether something else happened and whether it was just the shock which resulted in the child requiring ECMO in the first place. But then you need to think about, what treatments are you going to introduce? Now, hopefully with a 12-week-old baby, you're not going to have too many dietary lifestyle advices, but actually we are seeing increasing obesity, and there's data which is out this year in neonates and infants in the first year of life has long-term cardiovascular risk factors as well. So obviously a lot of the work I do is looking at causes of secondary hypertension, and very much where they are renal in origin, and a small section, usually about 10%, which is a lot of our work that we do, is in renovascular hypertension. And what we see is that as children get older, the spectrum kind of changes. And obviously we always have to think about the basics when looking at dietary advice and looking at obesity. But actually we see an increasing incidence of renovascular hypertension, although I have seen a 10-month-old infant with a systolic blood pressure of 300 millimeters of mercury due to renovascular disease with renal artery stenosis. So let's get back to the beginning. What is a normal blood pressure? And does it vary with age? Well, the answer is yes. And what we did is we got rid of this beautiful mercury sphygmomanometer. We're still part of the European Union, so we can say that. But what they did is they said, you're allowed to have your barometers on your wall with mercury anywhere you want, but we must stop using mercury. Oh, and by the way, we don't really have anything else that's validated in children, but you need to institute this tomorrow. So we were in a bit of trouble when the changeover happened. So the question is how are you going to do it? And actually having casual blood pressure measurements and having a good auscultatory method is very good. But obviously what you require is good normative data on a normal population. So who can remember their medical student days and the Guyton textbook of physiology? It was never wrong, was it? So the blood pressure is the force was exerted by the blood against the unit area of wall, and obviously the systolic blood pressure is the highest blood pressure just at the moment of ventricular systole, and diastolic blood pressure is immediately beforehand. And that's the diagram showing the exertion on the wall. So most of you would say, well, obviously the best place to know what the blood pressure is actually to look inside, isn't it? So if you spoke to any pediatric intensivist, they would tell you the best blood pressure is an interarterial line. But I would disagree, because actually, A, this is not a normal population. You've got a ventilated child usually when you've got an intra-arterial line, although sometimes it is done for children who are hypertensive. But we are in the situation of having a catheter inside the vessel, and that changes the dynamics and the flows. So even with beautiful zeroing of the traces on the monitor, even with flushing and checking you don't think there's any thrombi, I've done manual blood pressures in children in pediatric intensive care and can get a value which is 30 millimeters of mercury different. And there isn't good data about what is the normal blood pressure, but obviously there's normal blood pressure in sick children who are ventilated in intensive care. So obviously the best way is actually using a Doppler ultrasound, and basically a lot of the machinery that you've got, the Dynamap, and you keep on pressing that button, do you know how it tells you what the blood pressure is? Well, actually what it does is it knows the mean blood pressure, and each company has got its own algorithm for each individual machine, which then gives you a derived systolic and diastolic blood pressure that it makes up with a formula. Not very scientific, I would say, in children. So what is high blood pressure? Well, it's easy in adults because we can talk about epidemiological, we can talk about the risk of having an adverse event, and we can talk about reversing that risk. And this 140 over 90 millimeters of mercury is now actually debated, because if you're slim, healthy, non-smoker, without a family history, with a normal lipid level, with a blood pressure of 140 over 90, probably, even if you're doing exercise and maximizing, the chances of you having an event is small. And you could do more harm by being on medication. So maybe this needs to be higher depending on what your risk strategy and your risk profile is. But in children, we don't have this. We use a statistical value based on the 95th centile for age, sex, and height centile. And I don't think Professor Stevenson would tell you that we should change our charts for weight because we're all getting obese. And likewise, I wouldn't say that what we need to do is to change the centile charts for children's blood pressure, because we know that the blood pressure has changed in developed countries over the last 10 years. So in adults, what we can show is by reducing your blood pressure, that we can reduce your cardiovascular events, we can reduce your fatal and non-fatal cerebrovascular events, and we can reduce your fatal and non-fatal coronary events. All of them show statistical significance when you do the meta-analysis and the systematic reviews. So the best that we have, and I put this in the handout, really is the American Fourth Report. We have some data in the United Kingdom as well, but I still think these charts, which were derived, are the best that we have, and there is discussions about updates coming out. And what you have is a different chart for boys and girls up to the age of 18, and what you do is you look at the centile height of your patient and where they are, and then you look at what their blood pressure, and it gives you the 50th, the 90th, the 95th, and the 99th centile. And the same for girls as well. So now that you know what to do, what can we tell you about children? Well, children rarely have an actual renovascular, so renal artery stenosis, but the children that we see are much more complex than in adults. And there is bilateral and segmental disease, and we see abnormalities of the small vessels, usually because of late diagnosis. Every year, I will see on average about 4 children who have an anesthetic for usually adenotonsillectomy, where the blood pressure is noted to be significantly elevated. Sometimes it is so high that the operation is cancelled, but normally it proceeds and nothing else happens until they actually present with a facial palsy or a cerebrovascular event. And I've had a few children who've represented with stroke within 12 months of being noted to be hypertensive because someone says a child can't have that high blood pressure. So the majority of causes we think are of renal artery stenosis and renovascular disease is due to fibromuscular dysplasia, which of course is histological diagnosis, and we very rarely get a tissue sample. But we very often see, when we do renal angiography, this kind of string of beads that you see here with post-dilatation aneurysm that you can see there. So what tests should we do? Well, as I said, to me the gold standard should always be is this child hypertensive? And we should do 24-hour ambulatory blood pressure monitoring. Now, you can only do this in older children. We can do it in the home environment as young as 5. For younger children, very often they need to have a lot more time spent with them, especially if they're going to wear the backpack and the monitor at home. And for very young infants, obviously, we need to admit them to have regular blood pressure monitoring on the ward environment. But what is good is it's helpful because it gives you a lot of data. It allows multiple measurements, and measurements which can happen in the usual environment, so when they're at home, when they're at school. And the other thing to say, which has also come out, is that the usual environment is important because actually adult medical care is changing so much so that there is a big debate about whether we should stop measuring clinic blood pressures in adults altogether. So you either do home blood pressure monitoring by having a validated automated machine, or you have a 24-hour ambulatory blood pressure monitoring, but you shouldn't just do a screening blood pressure in clinic. And what you do is you get data like this on children. And the reason I showed you this particular one, which is quite common, is that we very often tell our kids to take medications in the morning if they're on one drug because it's easier to remember when you get up, you put it next to you. Adherence is obviously a big problem, especially if you don't have any symptoms from your hypertension. And every time this child comes to see me, because my clinics are in the morning, his blood pressure is always very normal. But in fact, this is a very abnormal trace showing that in fact he doesn't have much nocturnal dip. It rises, in fact, to some of the highest values in the middle of the night when he's asleep. And as you can see, his blood pressure is only really low in the morning. So when I see him in clinic, I'm very happy with his clinic blood pressure, but I certainly am unhappy with his 24-hour blood pressure control. And this gives us data on the systolic and diastolic whilst the wake and night periods, and can help us assisting when to give medications and which medications. And one of the first things that children do is they lose this nocturnal dip in their blood pressure. And people are putting this down to is it related to stress, poor sleep, and in fact there is a very good correlation between sleep patterns and blood pressure management. So looking at the kids as well, going back to basics about seeing if there's anything that gives us a clue, for example, an underlying vasculitis. Are we dealing with a child with a glomerulonephritis or neurocutaneous stigmata, such as neurofibromatosis? And this year I've actually diagnosed a couple of children with very subtle signs of neurofibromatosis that actually were only referred because of high blood pressure, which was noted on screening. And then the question is target organ damage. Is there evidence of damage which you can have, such as left ventricular hypertrophy, which against the textbooks is actually reversible in children, and also if there's any evidence of hypertensive retinopathy, as well as any evidence of renal impairment and encephalopathy. And here you can see changes of hypertensive retinopathy with some hemorrhages and evidence of left ventricular hypertrophy. And you can calculate an echocardiography looking at the left ventricular mass index. So Stephen and I did not share slides, but we also have a chicken and egg scenario, because very often we see children who've got high blood pressure and they may have some evidence of proteinuria. The question is, do they have damage as a result of the high blood pressure, or do they have a kidney problem which is giving them high blood pressure and other features such as proteinuria? And we will do a myriad of investigations to try and work out why. So background studies looking to see if there is a cause, looking to see if there's any proteinuria. I don't routinely do chest x-rays anymore, although many people still do, because I feel we get enough evidence from ECG and echocardiography, and then targeting with an abdominal ultrasound with DOP. And this is because ultrasound is actually cheap, safe, it's painless and repeatable, but in fact, although the sensitivity is pretty good at 80%, the specificity for renovascular disease is pretty poor, but does depend on who's doing the scan. And what we can sometimes see is actually narrowing of the abdominal aorta, so mid-aortic syndrome, very similar to what you see with coarctation of the aorta when you've got obviously a lesion in the thoracic aorta. And then we do targeted investigations if we've got children who are more difficult to treat. And these basically look for underlying cause which can help. And actually, although we're in the situation of having very good investigations that we can do, very often in children I would actually go for digital subtraction angiography as opposed to CT or MRI because of the resolution in our learning phase with these studies, but because I see missed cases, both false positives and false negatives. And of course you may want targeted investigations, for example, if you're considering a pheochromocytoma, either from the history, examination or biochemical results. And here's a patient where we could actually see in the abdominal ultrasound an adrenal mass and a change in the MIBG with the uptake, which is consistent with a pheochromocytoma. So, in summary, we published in The Lancet a few years ago what we suggested as a process by which you could undertake investigations. So repeating blood pressure measurements, doing 24-hour blood pressure measurements, and then if you have confirmed blood pressure, which is between the 90th and 95th, a suggestion that we should monitor. But of course this means that 10% of all children in the United Kingdom should have their blood pressure monitored. Who's going to do that and where? And then if you've got high blood pressure above the 95th centile, then if you think they've got renovascular hypertension by any causes, then go forward for a digital subtraction angiography. But if there are no causes or signs, your blood pressure is poorly controlled, and usually on at least 2 agents, then we would go forward and we put here pre and post capture pulse scintigraphy. Normally we would just do a DMSA scan nowadays, and we probably would go to digital subtraction angiography sooner rather than later. So in summary, I think that high blood pressure in children is difficult, but it is a risk factor. It is not a disease in itself. So you always have to think is what is the cause? What's the etiopathogenesis? Is it a child who's fluid overloaded? Are they unwell? Have they got acute kidney injury? Is it renin mediated? Is there signs of glomerulonephritis? Is there microscopic hematuria and proteinuria? And very often, I think the etiology will lead to the treatment. Thank you very much.